Hi, and welcome to this 14 Fish Learning module. My name is Mohammed Sheikh, and I'm a doctor working with Mark. Today I'm going to be covering the second part in the series of the AKT package, where we're going to be talking about the administrative section, which is not the easiest to revise for. We're going to talk about the GP's role in certification, covering things like sickness, death certification, as covering things like sickness, death certification, as well as maternity, some elements of practice management, as well as prescribing. Let's get right into it. In terms of certification, when patients come in requesting a fit note, for example, we need to keep them informed that they are able to self-certify up to 7 days of their sickness. They must provide their employer with proof of sickness if they are longer than 7 days of being sick. They must provide their employer with proof if they are sick for longer than 7 days. That's when they'll come to you for a fit or a sick note. This can be done on the day of your assessment or retrospectively, and that can be based on your previous assessment or the written report of an allied health professional. The Med 3 notes, otherwise known as fit notes, cannot be prospective. They can only be retrospective or done on the day. The Med 3 notes have recently changed. They provide an option for the doctor to effectively determine whether a patient is not fit for work or if they may be fit for work, taking into account a few factors. What this basically enables the employer to do is make some adaptations to try and accommodate for the patient to have either a phased return to work, where they may take into account adapted hours or tasks to try and support their transition back into work from a period of sickness. If, for example, no agreement can be reached between the employer and the employee about their return to work, then the patient is deemed not fit to work until they're able to return back to their normal duties. It's important worth mentioning here that during the first 6 months of sickness, the new statement can only be issued for no longer than 3 months. This provides a nice segue into statutory sick pay, otherwise known as SSP. Statutory sick pay is a weekly payment in the amount of about £94.25 for patients who are too ill to work. Patients, in order to be eligible for statutory sick pay, must be off work sick for 4 or more days in a row, and it's paid for by the employer for up to 28 weeks. Patients can't get less than the statutory amount, and they might actually be eligible for more depending on their contract. So it's necessary for them to defer to their company's sick pay scheme or their individual contracts. Patients who are ineligible for statutory sick pay, or if their statutory sick pay ends after that period of 28 weeks, may then be able to apply for universal credit, or what's known as Employment and Support Allowance, also known as ESA for short. ESA is a financial support for patients who are unable to work, and it basically allows for personalized help so that they can get work if they're able to. There are two types. There's a contribution-based ESA, or there's an income-related ESA. In terms of income-related ESA, that's being replaced by universal credit, and in order to be eligible for ESA, you have to be under the state pension age. You also must not be receiving other forms of benefits, for example, statutory sick pay, statutory maternity pay, or job seekers allowance. As GPs, we may be involved in patients applying for ESA when they fill in the form ESA 113. There are 2 pages where healthcare practitioners, i.e. us as GPs, will be requested to provide some further information about our patient, their condition, and their limitations in seeking employment, for example. When a patient applies for employment and support allowance, it's a roughly 13-week process, and there are a list of outcomes, 3 outcomes that can result from that assessment. A, they can be deemed fit for work, and while they're searching for work, they're entitled to job seekers allowance. B, they are deemed to have some limitations in their abilities, and they might be referred to a work-related activity group. Or C, they are not expected to work at all, and they get put in what's called a support group. Those in the support group receive a higher banding of pay, and those who are fit for work will obviously receive the lesser band. After this assessment, no more Med 3 or FIT notes need be issued to these patients because they have their ESA payment. Unless they have a decision that doesn't go in their favor, they're appealing their ESA decision, and they would then require ongoing sickness certification or Med 3s. And also, you feel that they are unfit to work. Because we talked about patients being eligible for ESA if they're under the state pension age, I thought it's just important for us to revise what the state pension age is. And this is currently under review by the government with the current increasing in life expectancy of the UK population. In a nutshell, if your date of birth is on or before April 5, 1970, there's no change in your pension age. If, however, you were born between April 6, 1970 and April 5, 1978, your pension age will be 67, or between 67 years and 1 month and 68 years, depending on your date of birth. Patients can always refer to the government.uk website to verify this. If you're born after April 6, 1978, there's no change and your pension age remains at 68. So we talked about ESA, particularly after statutory sick pay ends after 28 weeks, but we also covered how when you're at that fork in the road, when 28 weeks is up, you can either apply for ESA or what's known as universal credit. Universal credit is different in that it's a payment that helps people with their living costs, and people may be eligible if they have a job but they have low income, they're out of work, or they're just struggling to get by. The universal credit, in the term universal, it replaces a lot of other benefits that existed before it was introduced. And some examples are child tax benefit, the housing benefit, income support, income-based job seekers allowance, income-related ESA, as we talked about earlier, and working tax credits. Another form of benefits are known as the Personal Independence Payment, or PIP. And PIP effectively helps with costs if you have a long-term ill health or a disability. The amount depends upon how much the condition affects you, not so much as the condition itself. In order to be eligible for PIP, which replaced DLA, otherwise known as the Disability Living Allowance, patients must be aged between 16 and 64 years of age. They must have lived in the UK for 2 of the last 3 years. They must have a condition which affects their activities of daily living. And those activities of daily living, the effect that their condition has on them, must have happened for 3 months and must be expected to last over 9 months. Patients, when they apply for PIP, they have a face-to-face assessment, And depending on the outcome of the assessment, there are two components which they may receive support for. So there's a daily living component, and they will receive support and funding if they need help with preparing food or eating, washing, bathing, using the toilet, dressing and undressing, basically their day-to-day activities of daily living. Second component is the mobility component, and patients will be assessed whether they're able to walk, if they can only walk a short distance without severe discomfort, if they could become ill if they walked certain distances, or, for example, if they are amputees. Patients who are over 65 may also be entitled to claim attendance allowance. Attendance allowance helps with extra costs if patients require extra supervision and help with a chronic health condition or a disability. This disability can either be a physical, mental, or both. There are two bandings of payments, either a low or high, depending on how much supervision these patients need. We mustn't also forget about carers, who can also claim for carers allowance. And the eligibility for applying for carers allowance include carers being over 16, and the person that they care for must receive an attendance allowance or a mid to high rate personal independence payment. The carers need not be related or living together with the person that they care for. In terms of terminal illness, which is defined by the Social Security legislation as a progressive disease, where death as a consequence of that disease can reasonably be expected within 6 months. With terminal illness, claim for benefits can be fast-tracked and paid at the highest rate. Patients can, with the support of the GP, apply for, under special rules, for their personal independence payment or disability living allowance or ESA or universal credits under Form DS1500, which basically requests information from the healthcare practitioner, i.e. us as GPs, about factual, not prognostic information about a patient's health condition. The diagnosis is really important to cover in this form, whether the patient is aware or unaware of their diagnosis, because if they're unaware of their diagnosis, it may be important for the communication from the Department of Work and Pensions to liaise with their representative. Also, what goes on the form that's important to note are the current and proposed treatments, as well as the brief details of clinical findings when the GP last saw the patient. After a successful DS1500 application, the patient can continue claiming even if their life expectancy surpasses that 6-monthly mark. They're entitled to for up to 3 years, at which point that decision is then reviewed. Whenever you're in doubt with any form of benefits, or if your patient comes to you and is asking for your support in terms of applying for be it ESA or PIP or universal credit, just know that you're not alone, and you can always refer them to the Citizens Advice Bureau. And if you're ever uncertain, you can always consult with one of your colleagues. But for the purpose of the AKT, I would urge you to read through the Government UK website, which covers all of these forms of benefit in great detail. In this next section, I'll be talking about maternity certification and covering the MAT-B1 form. Women who fall pregnant need to provide evidence of their pregnancy to their employer. That enables them to claim maternity benefits, which are otherwise known as statutory maternity pay or maternity allowance. In order to be eligible to claim for statutory maternity pay or maternity allowance, you must have been employed or self-employed for 26 weeks with your employer. Those 26 weeks need not be in a row, but must have taken place in the 66 weeks preceding the date of birth, or the date of delivery, rather. Statutory maternity pay or maternity allowance is paid for a maximum of 39 weeks, and payment can be started at the earliest 11 weeks before the expected week of confinement, and at the latest the day following the baby's birth. You can only issue a MAT-B1 form after 20 weeks of gestation. In this next section, I'm going to be talking about death certification. GPs can complete a medical certification of cause of death, otherwise known as an MCCD, provided they had seen the patient who died during their final illness as well as within the last 14 days of life. There are some important things to note with regards to completing a death certificate, and that is you can only list old age as the 1A, the primary cause of death, if the patient was at least 80 years of age. Natural causes is not an acceptable term to be using on a death certificate. And if you're going to be listing organ failure as a cause of death, it can only be used if you specify a disease or condition that initially led to that organ failure. So in the example of heart failure, you need to list myocardial infarction as the leading cause. Abbreviations should generally be avoided, except in the case of HIV and AIDS. And after completion of the death certificate, the patient's families then take that certificate to the local registrar of births, deaths, and marriages to register the death. Patients who wish to be cremated, forms need to be completed by the GP and other independent practitioners. So the GP will complete what's known as the CREM 4 form, and that would be done by the GP who is looking after them in their final illness. And then a CREM 5 form is then completed by an independent doctor who's been registered with the GMC, full registration for 5 years. If a patient dies while they were under a deprivation of liberty safeguard, a GP cannot issue a death certificate. What a GP can do is confirm death, but effectively what needs to happen is the care home or the institution where the patient was must notify the coroner. At that point, the coroner will issue an interim death certificate so that the family can register and make necessary arrangements for the funeral, for example. But the local coroners will then conduct a formal inquest for every person who dies whilst under a deprivation of liberty safeguard. It's also important to be aware of when we as GPs need to refer to the coroner. And that is when we are unable to confidently verify a cause of death. If a doctor or GP did not treat the patient within the last 28 days of life, if a doctor did not see or treat that person during their last illness in their last days, if the cause of death was sudden, if the cause of death was murder, if the cause of death was as a result of an industrial disease, and if the death occurred in any other circumstances that require investigation. In this next section, we're going to be talking about some elements in practice management, but I would encourage you to read through the AKT content guide to make sure that you look through some of the curriculum objectives required for practice management. It's important to know who's eligible for free healthcare under the NHS. Patients who are resident in the UK can have access to free NHS registration form. Patients who are visiting from overseas look through some of the curriculum objectives required for practice management. It's important to know who's eligible for free healthcare under the NHS. Patients who are resident in the UK can have access to free NHS healthcare, and you can register with a GP practice by completing a GMS1 form, otherwise known as the Family Doctor Services Registration Form. Patients who are visiting from overseas, if they're staying less than 6 months, do not fulfill qualifying criteria for non-emergency NHS care. If patients are visiting from overseas and they're staying for longer than 6 months, then they are entitled to non-emergency NHS care, and their entitlement begins on the date of their arrival to the United Kingdom. British nationals who return to the UK may be coming back from a business trip or an extended holiday. They're treated as any other normal UK resident would be. But someone from the UK who has emigrated and ordinarily lives abroad would need to be treated as a patient from overseas. The onus is on patients to inform the relevant authorities and surrender their medical cards if they leave the UK for more than 6 months. In terms of temporary residence, you can receive emergency treatment from any GP surgery if you're not registered already and you need to see a GP. If you need treatment for more than 14 days, you must register as a temporary or permanent resident. In order to register as a temporary resident, you must complete what's known as the GMS3 form for temporary residents. This enables access to care for patients for up to 3 months, after which they would need to apply to register as a permanent resident. In addition, if a patient's going away on holiday and requests that you issue them with their repeat medications, it's important that you do so in line with when their repeat medications were due. For overseas visitors who require emergency or immediate care, they are entitled to free NHS care for up to 14 days. There's no obligation to provide non-emergency treatment to these patients. Refugees, whether or not they're awarded leave to remain in the United Kingdom, are regarded as ordinarily resident. In terms of complaints, sometimes you might be on the receiving end of a complaint. Hopefully they're more compliments, but they should be acknowledged within 3 days by writing or telephone, with a record made noting that acknowledgement has been sent to the patient. Practices must appoint a complaints manager, and complaints can be made by a patient up to 1 year after the incident. There's no set time frame as to when we are expected to respond to a complaint, but what's generally accepted is that it's done so within a reasonable time frame. In the past, there were time frames that were recommended that practices adhered to, but it wasn't always practical when you'd have a GP that was maybe away on leave or that was off sick, for example. In this next section, we're going to be talking about medicines management and prescribing. It's important for your AKT revision, and I would save this again for the last part of your revision, that we need to know about some of the drug monitoring criteria for patients who take, for example, disease-modifying antirheumatic drugs, or DMARDs for short. And I'm just going to be covering some of the examples of drug monitoring for some of these medications. But again, this list isn't exhaustive. Patients who are on methotrexate, it's important to check their full blood count, LFTs, UZNEs 1 to 2 weekly, especially when initiating, and then thereafter 2 to 3 monthly. Those patients who are on azathioprine need a full blood count and liver function test before treatment, and a full blood count weekly for the first 4 weeks. Patients who are on levothyroxine must have an annual TSH. Patients who are on statins require liver function tests at baseline, 3 months, and then at 1 year. Patients who are going to be commenced on ACE inhibitors require urea and electrolytes prior to starting treatment. And then 1 to 2 weeks after starting treatment and after each dose increase. Their UZNEs should be monitored at least annually thereafter. Patients who take amiodarone require liver function tests, thyroid function tests, UZNEs, as well as a chest x-ray before starting, because amiodarone can lead to pulmonary fibrosis. Thyroid function tests and LFTs every 6 monthly, and a chest x-ray is required annually. It's also an important note to bear in mind in checking patients for optic neuritis if they take amiodarone. Patients who are on lithium require lithium blood tests every 3 monthly if they're stable. You want to aim for a level between 0.6 and 1 millimoles per liter. You want to be particularly cautious in the elderly and pay particular attention if their lithium level exceeds 0.8 millimoles per liter. In addition, patients who are on lithium require UZNEs and thyroid function tests every 6 months. Another important aspect to revise for the AKT are your drug calculations. And I'm going to run through a couple of easy drug conversions for you so that you can try and commit these to memory, as it will also help your practice as future GPs. When prescribing opioids, it's important to know that your subcutaneous dose of morphine is half of the oral dose. The subcutaneous dose of diamorphine is 1/3 of the oral dose of morphine. And the breakthrough dose of opioids is going to be 1/6 of the total intake of their opioid in a 24-hour period. So for example, if a patient is taking 30 milligrams twice a day of morphine sulfate, that's 60 milligrams in total in a 24-hour period. So 1/6 of 60 milligrams is 10 milligrams of morphine, which would be their breakthrough dose. There are a list of criteria in order for patients to receive free prescriptions under the NHS. To save you the hassle of me reading through this list, I'd encourage you to read about this online. But effectively, some important points to note is if you're aged 60 or over, or if you're under 16, or if you're between 16 to 18 and in full-time education, you're entitled to free prescriptions. Or for example, you're an NHS inpatient. Some other exempt conditions include patients who have a diagnosis of cancer, hypothyroidism, diabetes. They're also eligible for free prescriptions. There are a lot of other conditions that enable patients to have free access to prescriptions. As I said, this list isn't exhaustive. It's also important to note how to use the BNF and interpreting some of the symbols that are used, as you might also be examined on this in the AKT. What we'll do is include some of these symbols that are used in the BNF, which may help to guide your interpretation of some of these symbols. There are some elements of non-medical prescribing which we need to understand as well. You have patient group directions, which basically provide a legal framework which allows certain healthcare professionals to supply or administer specified medicines to a defined group of patients. So for example, the flu jab. Another form of prescribing is what's known as the patient-specific direction, which is a written instruction signed by a prescriber for medicines to be supplied and administered to a patient after the prescriber has assessed this patient. It may be referred to as a prescription, which has been written and followed by the person administering it, but it's different from an FP10 or a prescription that a patient then takes to a pharmacy or a dispensary, for example. That concludes the second part in the administrative section for your AKT revision. I wish you all the best for your revision. If you have any questions or comments, please do let us know. Hi, and welcome to this 14 Fish Learning module. My name is Mohammed Sheikh, and I work with Mark in Hampshire. Today I'm going to be talking about driving and flying restrictions. Now, this is primarily aimed at those who are about to sit the AKT exam. And just so you know, I can completely share your pain having just recently sat and passed this exam. Off the top, this subject is pretty tricky to revise for, but it's important because they form about 10% of the questions you're going to face on your AKT exam. And it's not just the DVLA restrictions and on driving and flying, but also on administrative changes and regulatory frameworks, which will be covered in subsequent videos. If there's one thing I can impart upon you, it's to try and save revising for this subject towards the end of your revision. What you'll find is there are myriad conditions that can affect driving, that can affect your safety to operate heavy goods vehicles, for example. And it's going to be requiring a lot of rote learning to cover some of this material. So my advice is cover the main topics and save this for the end part, because remembering how many weeks off driving can be quite tricky. So committing it to memory later on in your revision might serve you better than starting with it. Some resources that helped me in my revision and also guide this presentation will be pasted along the left side hand of this video. But just so you're aware, the DVLA publish a very useful guide called the Assessing Fitness to Drive, a guide for medical professionals, as well as Health Education England's DVLA guidance for the AKT exam, and then also just covering some of the curriculum content from the RCGP's AKT content guide. As future GPs, it's very important for us to understand what our role is in terms of communicating to patients the fact that their condition may impair their ability to drive. The patient then has a legal responsibility to inform the DVLA of their condition and how that can affect their ability to drive. The DVLA's role is then in deciding whether that patient is fit to drive or not. That then begs the question, what if my patient refuses to inform the DVLA? Well, we as GPs should do whatever we can to empower patients to disclose this information to the DVLA, but we may be encountered by some of those who refuse
doesn't.
Hello? Yeah, hi.
License is withheld until the patient has been free of their alcohol misuse for 6 months. This also applies to patients who misuse cannabis, amphetamines other than methamphetamines, ecstasy, and other psychoactive drugs. In contrast to patients who demonstrate that they have an alcohol dependency issue, their license is withheld for 1 year. Also, a 1-year restriction of no driving is also placed upon those who misuse heroin, cocaine, methamphetamines, and benzodiazepines. It's also important to disclose to these patients that they must notify the DVLA of their condition. And back to what we were saying before, if they refuse, we must explain to them that if they do refuse, we would be forced to disclose to the DVLA. The next topic I'm going to be covering cardiovascular conditions, and I'm going to start by talking about acute coronary syndromes. Restrictions placed upon driving will vary depending on what kind of intervention a patient has following an acute coronary syndrome. Some of those patients may go on to have a coronary angioplasty, and it depends if that procedure is successful or not. If the coronary angioplasty is successful, a patient must refrain from driving for 1 week. And if it's unsuccessful, or if they have an acute coronary syndrome and they do not go on to have an angioplasty, they must cease driving for 4 weeks. They do not need to inform the DVLA after having a procedure like a coronary angioplasty. Some patients may undergo percutaneous coronary intervention, otherwise known as PCI. Patients who have PCI must cease driving for 1 week, and again, there's no need to inform the DVLA. Other patients who undergo coronary artery bypass grafting, otherwise known as CABG, they must cease driving for 4 weeks, and they again do not need to inform the DVLA. Patients who have angina must cease driving if their symptoms occur at rest. Also, they mustn't drive if they have angina that's precipitated by heavy emotion or even driving. And I mean, a bit of common sense comes into play here. Would you want to be in a car with someone who had angina at rest? I don't think so. So you'd want to communicate this to your patients and also think about how their condition might affect their lives, be they driving or not. But again, they do not need to inform the DVLA for this condition. Patients with heart failure don't have a restriction placed upon them for driving unless their heart failure is so severe that they fit the New York Heart Association's Class 4 level of breathlessness. And just to refresh your memory and my memory, that is when people are unable to carry out any physical activity without discomfort. They may have symptoms of heart failure at rest, and any physical activity that they undertake is brought on by an increase in their level of discomfort. So again, much in the way of a patient who's symptomatic from their angina at rest, if they have severe heart failure, you would not want them to be driving a car. And that is when they should not be allowed to drive. Furthermore, if they have Class 4 New York heart failure, they need to inform the DVLA. Patients who have hypertension, they don't have a restriction placed upon them, and they do not need to report this to the DVLA. And then we come to the topic of arrhythmias. Patients who have arrhythmias must cease driving if their arrhythmia is likely to cause any incapacity. They can resume driving when the underlying cause of their arrhythmia is addressed and has been controlled for 4 weeks. Patients who have a successful catheter ablation need not drive for 2 days following that procedure. There's no need to inform the DVLA of the condition unless they are symptomatic from their arrhythmia in terms of the arrhythmia disabling them, or distracting them, as that can have a bearing on their ability and safety to drive. Patients who have pacemakers put in must not drive for a week, and they must inform the DVLA. I'm now going to talk about people who have strokes or TIAs, otherwise known as transient ischemic attacks or mini strokes. Patients who have strokes or TIAs have a driving restriction placed upon them for 1 month. They do not need to inform the DVLA unless, after 1 month of not driving, they still have a persistent neurological deficit. In those situations, they might need to go some further testing to assess whether they're safe to drive. So just to recap, we've talked about a lot of cardiovascular conditions that may have a week or 4 weeks restriction. So I've made a small table here to categorize those restrictions for 1 week versus 4 weeks. So 1 week restrictions include those patients who have a successful angioplasty, a successful percutaneous coronary intervention or PCI, or they have a pacemaker. But remember, for pacemakers, you must inform the DVLA. 4-week driving restrictions are for those who have unstable angina, an NST elevation MI, otherwise a non-ST elevation MI, or patients who have an unsuccessful angioplasty. Another category for patients who have a 4-week restriction placed upon them for Group 1 licenses, again, are those who undergo a CABG or have heart valve surgery. There's a helpful table from Health Education England's AKT guide or the DVLA guidance for the AKT revision. And what that basically does is it summarizes everything I've just talked about, but it also compares and contrasts the restrictions for Group 1 and Group 2 license holders. So I would encourage you to have a read through those documents and also just have a look at the ICD implantation, because it also differentiates between whether you have an ICD put in for prophylaxis or for treatment of VF or ventricular fibrillation. In the next section, we're going to be talking about diabetes. I've categorized diabetes according to how the DVLA see it. And I've made it into 3 categories. So the first one will be diabetes managed by diet or metformin. The second will be diabetes that is managed by medications other than metformin. And then in the third category, we're going to be talking about insulin-dependent diabetes. Simply put, there's no restriction put on Group 1 or 2 license holders if they are on metformin or they are controlling their diabetes by way of diet. If they manage to show good control and no complications with their diabetes, there's no restrictions placed upon them. The second category or group of patients who are diabetic and are on other antihyperglycemics, i.e. they're not on metformin and they're on glycoside or pioglitazone, for example, there is no restriction on Group 1 license holders provided they have no more than 1 hypoglycemic episode in a 12-month period that requires the assistance of another person. So again, if you are a type 2 diabetic and you're on an antihyperglycemic other than metformin, you must demonstrate that you haven't had any more than 1 hypoglycemic episode in a 12-month period that requires the assistance of another person. If, however, you're a Group 2 license holder, you not only need to demonstrate that you haven't had more than 1 hypoglycemic episode in a 12-month period, but also that you monitor your blood sugars twice a day, that you demonstrate full hypoglycemia awareness, and that you're aware of the risks of hypoglycemia. And again, this goes hand in hand with understanding that patients who have Group 2 licenses are driving heavy goods vehicles. They're more of a risk on the road than a Group 1 license holder. Patients who control their diabetes with insulin have far more restrictions placed upon them. For Group 1 license holders, there is no restriction, and they're issued with a 1 to 3 year license if they have no more than 1 hypo in 12 months, that they also demonstrate full hypoglycemic awareness, and they also monitor their blood sugar 2 hours before setting off on a journey. And if their journey